All right, so just a little bit about me. I became a dietitian back in 2014, and then went back to school for my master's in counseling in 2019. So right now I work dual credentialed, which means I either am a dietitian or a counselor, depending on the client. So I never do both with the one person, but I will kind of do one or the other depending on what the needs are, or the gaps in care, maybe. I've worked with both pediatrics and adults living with eating disorders across the various levels of care here in Canada. So, across outpatient, day treatment, inpatient, and residential, both in British Columbia and Ontario public health authorities. And then in 2020, I transitioned to private practice, mostly by telehealth. So, for those kind of like 4 years after, during, and after the pandemic, I stayed online, and my family moved a good bit about. And then mid 2023, we were able to come home, to St. John's, Newfoundland, and that is where I work today, just at a small office here. And so when I'm not in clinic, seeing folks and families with eating disorders, I may work in clinical education for family health teams, community pediatric groups, allied health teams, that sort of thing, across the country. So in terms of an overview, I recognize we've got 30 minutes, so I'll try and get through as quickly as I can, focusing a little on assessment and screening for eating disorders within the GI population, reviewing some common treatment goals, and then discussing the treatment interventions that we tend to see most often in the literature and in clinical practice. So in terms of why we want to ensure we're screening for eating disorders, with GI conditions, there is a high prevalence of disordered eating patterns in those with intestinal disease. Now, as Dr. Taft mentioned, um, these the screens are pretty tricky, so they may not be entirely reliable. This is quite a large range, being 5 to 44%. And then the other piece is that some, perhaps maybe the majority of clinicians may struggle to recognize the presence of eating disorders among those with intestinal disease. And as Dr. Taft mentioned, most eating disorder screening tools, so for ARFID and of course for the other eating disorders as well, so anorexia, bulimia, binge eating disorder, um, they also haven't been really validated with this population. So we use them as a guide, as a conversation point, but definitely not as the backbone of our assessment process. So in terms of the assessment process, we want to consider what the risk factors for the development of an eating disorder may be. And so for this presentation, I focused very much on the risk factors within the GI population. I didn't spend time talking about the general risk factors that would be seen kind of more commonly across all eating disorder diagnoses, in the Gen Pop. So this is specifically to GI, and we're looking at eating habits, medical findings, and then mental health status. So when it comes to eating habits, we want to first start by assessing the degree of the current dietary restriction, if it's present. I would always ask if there's a history of, or if the patient is currently following some sort of therapeutic or elimination diet. We do see some of the numbers in the literature around patients with a history of the self-started elimination diets being over 3 times more likely to meet the diagnostic criteria or a screen, for ARFID symptoms. Another piece is a low level of food literacy. So inadequate food literacy levels have been associated with an increased risk of developing ARFID in patients with IBD. Basically looking at where food beliefs and food knowledge is and how that correlates with their adherence, to certain prescribed diets. And then with relation to confirmed allergies or intolerances, food literacy helps patients determine which food items are safe for consumption and thus may prevent over-restriction of recommended foods. Now, I have a little aside here. When it comes to allergies and intolerance within the eating disorder population in general, it is common for patients to come in, stating they have longstanding food allergies or intolerances. Sometimes these have not been confirmed, and it can be a way to mask restrictive eating behaviors. So I just always encourage clinicians to be curious when folks present with allergies and intolerance. Ask a few questions, clarify where the diagnosis came from, how long ago, and perhaps even how they feel about that diagnosis if there is one. So it's just one of those things that generally I'm always cautious about. So just to plant that seed here today. Now, when it comes to medical findings, always consider the big picture. So medical history, clinical presentation. When it comes to a GI diagnosis, I encourage folks to ensure the patient's dietary restriction is appropriate for their current diagnosis. So for example, when it comes to IBS or irritable bowel syndrome, low FODMAP diet that would be individualized tends to be recommended. And then just making sure that we're considering who may not be a good candidate for such a restrictive diet. So a poor candidate may look like someone who's already eating a diet that's low in FODMAPs. Another one may be someone who already has an active eating disorder. And Dr. Taft and I just briefly mentioned this over email. There is instances, many instances perhaps, where folks have a pre-existing or underlying eating disorder that precedes the GI diagnosis. And so we don't really talk about that, or we haven't yet talked about it today, unless it comes up in the question and answer session. But it is something to be considerate of. And it may look different in clinical practice, whether or not an eating disorder diagnosis comes before, during/slash after a GI diagnosis. And then just to kind of finish that thought with the good candidates for the low FODMAP diet would be someone who consumes a high FODMAP diet and has access to really thorough patient education so that they can understand the details, the important details around implementing a low FODMAP diet temporarily. And then second, the severity of symptoms. So ensuring that we're screening for a history of severe or persistent, especially postprandial symptoms in IBS. There's a few studies that were done just back in 2020 where there's a higher prevalence of ARFID in severe or active IBD and those with abdominal pain and constipation related GI diagnoses. So again, just a little bit of a seed to plant there to kind of spark your interest when you're in clinic next, and you may see this sort of clinical presentation. And thirdly, mental health status. So Dr. Taft introduced the concept of quality of life, food-related quality of life. So doing some work around exploring their current level of food-related quality of life, as well as their general mental health status. So in terms of their levels of current anxiety and depression, with ARFID presenting in those with intestinal disease, the main driver we see is that fear of aversive consequence. And most commonly, I might hear this as a fear of getting sick, a fear of not being close to the bathroom, a fear of symptoms getting worse or becoming what they would feel is mismanaged. And so GI symptom specific anxiety is, based on this study, the most important predictor for ARFID development. And so dietary over-restriction may be caused by that pre-existing fear around the food intake and GI symptoms. And this is something I see quite often in clinical practice is clients and patients will report that while they may be interested in trying these foods or new foods or having more of the foods that they used to enjoy, the overwhelming fear that they will have symptoms overrides that desire. And so quality of life is quite poor in some cases. So it's definitely a consideration that I encourage all clinicians to consider. And then the presence of disordered eating or diagnosed eating disorders. And so that would look like screening for the physical, the emotional, and the behavioral signs that might indicate the presence of eating disorders in that patient at that time. And whether or not it's kind of active, long-standing, the type of eating disorder will influence the type of clinicians that I would encourage that were involved. And so most times an interdisciplinary approach is so valuable and especially important. The tricky thing that we're seeing, especially since the pandemic, unfortunately, is access to care. So since moving back to Newfoundland, we don't have ARFID services for adults in the public system. And so it's really tricky to have that interdisciplinary approach. It's feeling quite siloed here. And so hopefully that changes in the future, but definitely consideration, because I recognize for any clinicians that may be working rurally or kind of underfunded, understaffed, best practice is awesome. And we love to see that interdisciplinary approach. And it can be really isolating and feel lonely when we're out there kind of doing this work without anyone else to consult and share the clinical load with. So when it comes to assessing for disordered eating, I look at three kind of different subtypes of signs. So the physical, the behavioral, and the emotional. And specific to the GI population, physically, we're screening for the progressive signs of malnutrition. And based on this study here, these are the traditional signs of malnutrition. So, that common weight loss of 5% or more over 1 month, low BMI, less than 18.5. Perhaps it is less than 75% of estimated nutritional needs that has persisted greater than 1 week. It could be inadequate intake or a complete exclusion of any macronutrient or micronutrient that persists for longer than 1 week. And then nutrient deficiencies revealed on blood work. And once again, best practice is we screen, right? We want to screen for a lot of the micronutrients. Some of the most common deficiencies with ARFID are going to be the fat soluble vitamins, so A, D, E, and K, calcium, vitamin D, zinc, iron, big time iron. We want to see that blood work. And I mean, I struggled in Ontario to get adequate nutritional blood work, but being back out east, it's been particularly tricky. And if we can get it, then there tends to be quite a delay. So it could be 4 to 6 weeks waiting for a vitamin D status, for example. And so just keeping that in mind when it comes to access of care and what we're able to implement in the community or wherever we're working. And just an aside, the absence of weight loss does not necessarily indicate that the patient is not at risk of malnutrition. It's just simply that this is kind of what we might see in terms of body changes, but I don't want that to be black and white. And so behavioral signs, we might be screening for progressive maladaptive eating behaviors that may look like delayed eating, skipping meals, portion sizes being quite small, and usually clients or patients will say it's because they're afraid of GI discomfort. So they're afraid of getting sick. They're afraid that they will need the bathroom and there won't be access to one. They may avoid foods that are suitable for the prescribed diet, but again, due to that fear, their restriction has become compounded, I would say. So I had a client recently who presented with IBD, but she had whittled down to about 10 different foods. And in discussing kind of, the foundation, what led to that, basically any food that felt a little bit off then became a member of the absolutely never list. I'm not going to have that again. And so it's so relevant to what Dr. Taft spoke about in terms of that hypervigilance and being acutely aware, almost maybe searching for side effects, negative side effects, and then having that confirmation that, hey, yep, that did make me sick. That goes on the no list. And it gets really tricky when we're trying to find a nutritionally, dense diet, and we've got 5, 10 foods to work with that are very low calorie. So it gets tricky clinically. And then it might also look like eliminating entire food groups or all enjoyed foods for reasons beyond the prescribed diet. And so most commonly, and I'm sure this is probably not news to most folks, but it's common to see, no dairy, no gluten, of course, but across all diagnoses, not just celiac. It might look like no added sugar, no refined carbohydrates, no processed foods, just straight out, just nothing that comes from a package. So that's oftentimes something that causes me pause. And then I just get curious and explore that a little bit more with the patient to get some more information. When it comes to the emotional signs, psychological distress around food, so the negative thoughts around food might intensify. They may become more nuanced or more particular. Social interactions may become isolated, so they might become avoidant of seeing folks, especially when it involves eating in any way, shape, or form. Overall, mood might be more depressed. There might be an increase in anxiety, and oftentimes, again, coming back to that quality of life, activities of daily living may be significantly impacted. Um, and then negative effects on the mental and social health exceeds the benefits of the symptom improvement. So that might be kind of, say, a few months in to a therapeutic diet, and we're starting to see actually more negative outcomes than positive. It might be time to reevaluate the treatment plan or the treatment approach at that time. And to finish up the emotional signs, negative beliefs and attitudes that are associated with food. So patient might be unwilling or unable to regain lost weight that has been lost. The patient might refuse to discontinue an elimination diet despite it being helpful, or sorry, despite it not being helpful, or despite it kind of running its course. Or we might see that kind of apathetic presentation where the patient is unconcerned about physical or psychosocial dysfunction that might result from an elimination diet. So it's almost like it doesn't, what's most important to them is being symptom free. And therefore that trumps the other pieces that might be actually contributing to improved quality of life. I'm so conscious of the time. I'm afraid that I'm going to go over. I think I've got 10 minutes. Briefly, just touching on the screening tools because Dr. Taft did as well. So specific to RFID, the few that I may use clinically in practice here in Canada are these three. None of them have been validated with the GI population. So regardless of which ones we're using, just recognize that they provide some insight, might be a conversation point, but as Dr. Taft highlighted, we don't want to use them diagnostically or really just use them as a starting point. I don't want to get too anchored in what a screener may or may not say because it is just one piece of information that may not actually tell us much when used in these specialized or subsets of populations. Now, if the screen is positive, be cautious. So again, consider that overdiagnosis of ARFID in intestinal disease. If you are feeling that it's aligning with other clinical signs as part of your assessment process and you're still getting those flags around ARFID that are over and above what is coming up in the screen, you can share the results, or sorry, of course you can, but I would encourage you to share the results with the interdisciplinary team and then discuss how you might present that to the patient. So I would definitely preface with the fact that the screens are not they're not validated in this population. So it might just be, hey, I'm curious about these things that that came to light as part of the screener. What do you think of this? Always show compassion. So I really encourage that patient-centered approach. As Dr. Taft mentioned, medical trauma is so common within this clinical population. And so meeting them with kindness, meeting them with compassion can be really helpful in putting them, I don't want to say at ease, but maybe just turning down the hypervigilance a little. And then finally, providing support. So discussing next steps of whether or not that patient is interested in getting connected to treatment, kind of having an idea of, is there other people in the care team that may be helpful in furthering the conversation? Because oftentimes in GI clinic, that's not necessarily the space to be looking at the disordered eating in detail, but part of our job from that lens is trying to get folks connected to the right team. In terms of common treatment goals, when it comes to ARFID within this subset population, physically, we're aiming to meet estimated energy requirements daily. So really bringing that up, of course, that ebbs and flows, but the ultimate goal of trying to keep them nourished and reversing malnutrition, depending on the level that it is at upon presentation. Another goal might be adequate intake of macronutrients and micronutrients. So in other words, meeting the RDIs from food. Just an aside with that, when it comes to correcting nutrient deficiencies, I don't recommend correcting full nutrient deficiencies with food. Typically, there would need to be a therapeutic dosing of supplementation and then the adequate monitoring to make sure that the client or patient responded to treatment. And then oftentimes I will try and work up to food sources of the deficiencies so that once they are through the therapeutic treatment, that we have some kind of safety net when it comes to the foods that they are including in their day-to-day nutrition kind of moving forward. And then from a weight perspective, restoring weight loss or trying to get them to a well weight status versus being underweight. Behavioral, we would look at establishing regular eating. So consuming, 3 meals, 2 to 4 snacks daily, trying to get them more comfortable with adequate portions, consuming foods from all food groups that would be appropriate for their therapeutic diet in terms of the GI condition, and really looking at if we trying to overcome the barriers where they're eating very, very restricted amounts of very restricted food types. So trying to liberalize wherever we can, and challenging them to sit with a small amount of emotional and physical discomfort in order to continue to build on that ability to increase their overall food intake. And I will say, when someone has been undernourished for so long, it can be quite uncomfortable to eat again in adequate portions when the anatomical stomach is actually quite uncomfortable, and that's even in the absence of a GI condition. And so there's a perfect storm that can happen where the hypervigilance with any sort of GI symptom, we're kind of working against the biology where the anatomical stomach has really shrunk because of the ongoing undernutrition. And so asking someone to eat more food more often is actually a huge ask, and it can be very distressing for the patient. So I really take the time to work through that with the patient. I want to honor that it is a very difficult request or recommendation, and working with them to determine what feels comfortable or maybe feasible, and to what degree are they ready, willing, and able to kind of refeed, and really meeting them there, because I'm so cautious of over kind of recommending or over prescribing within the refeeding process for fear of increasing anxiety and creating creating medical trauma. So just another piece to consider in clinical practice. When it comes to the emotional side of treatment goals, we might be working on decreasing social isolation. So trying to expand their social events, look at maybe decreasing anxiety might be the easier way to say it, but decreasing anxiety around going to social events that involve food, trying to get them reintegrated into their social circles that overall may enhance their quality of life. Reducing anxiety around food and symptoms, of course, and then we may or may not target distorted thought patterns. So if there's anything that's kind of like looping for them, we might look at really targeting that and trying to reframe. Now, in terms of clinical interventions, I've got about 5 minutes, so I'm going to get through those as quick as I can. These are the most common ones. It's not the exhaustive list. There's multiple different interventions, and they can be used layered on top of each other. So I'm just going to go through them just to lay the foundation so that you folks have some context as to what may be being used out there. And then on my reference slide, you'll also see that there's lots of studies being done in different aspects that you might want to look at a little further. So when it comes to patient education, I always start here, especially when we consider readiness to change. If you're getting the sense that the patient in front of you is not, in that stage of change where they want to take action, or that they're even ready to prepare, they're just starting to contemplate, then I really anchor the appointment in patient education. My clinical goal tends to be keeping them engaged. So we might not be setting nutritional goals or treatment goals at the end of that appointment, but if I was able to share education, we were able to build kind of a sense of rapport and kind of lay the foundation of the psychoeducation side. That tends to be a great use of time in those first couple of appointments. So in situations where elimination diets are required, the patient education has been suggested in the literature to decrease the risk of the development of an eating disorder. And so we would be looking at the counseling targeting food literacy, so as mentioned before, as well as those risks associated with elimination diets. And you might notice that this is just kind of repeating back what we had looked at as part of the assessment process. So we would then be educating the patient on those. We'd be looking at their skills around meal planning, meal preparation, management of kind of feeding their bodies as in the big picture. And patients with that decreased ability to plan meals may be more likely to exhibit restrictive eating behaviors. And that can be for a myriad of reasons. It might be trouble with executive functioning. It might be overwhelm. It might be physical GI symptoms are debilitating. So they have no capacity to plan and prepare meals for themselves. I would also be looking at patient capacity to effectively implement the restrictive diet or the elimination diet. So really looking at what are the need to haves or need to do's versus the nice to do's, looking at the time frame. So in terms of the length of the therapeutic intervention, and just kind of getting an idea and setting the framework that also oftentimes it's more of a short-term intervention. It might not be lifelong, depending on the diagnosis. And then just spending time helping them learn how to safely navigate the restrictions without cutting out too much. I think a lot of times it is, and I mean, to be fair, it is easier to just blanket statement and say, I'm just not going to eat anything that has dairy, or I'm not going to eat anything that comes from a package. And it's unfortunately the risk with that is that we have restricted a lot of foods that didn't necessarily need to be restricted. And then with risk counseling, looking at, you know, there may be a risk with an eating disorder developing when we have significant dietary restrictions. I want to make sure we're highlighting the importance of food introduction, reintroduction as part of a therapeutic diet. I tend to emphasize that symptom control is clinically tends to be a main goal. And I may touch on the rates of eating disorders in intestinal disease, but kind of read the room. Many times I might not, because I don't necessarily want to add to anxiety, add to the hypervigilance, and I might not be actually adding any value by providing that information, and I might be doing harm. When it comes to anxiety management strategies, we would be just considering that anticipatory anxiety. So anticipating that a symptom may happen can play a significant role. And so I try and get back to basics, really looking at sleep hygiene, very light movement, deep breathing exercises. Some of the more kind of like treatment modalities might be mindfulness-based stress reduction, and general cognitive behavioral therapy. In this case, CBT would be targeting overall anxiety. There are some modified nutrition interventions for the GI conditions or GI population. So there's a FODMAP gentle approach that is recommended for IBS patients that may be at high risk for developing an eating disorder, or they already present with maladaptive eating behaviors. And so it's basically only the highest FODMAP foods are restricted. So it's kind of a hierarchy, and always considering that interdisciplinary approach. Now, in terms of primary versus secondary diagnoses, in some cases, in most cases, probably it is recommended to treat the active eating disorder, depending on severity, prior to initiating restrictive diet intervention. So it's a nuance, or it's nuanced, I should say. So just kind of something to consider. With traditional ARFID nutrition interventions, there's been a significant focus on increasing volume and increasing variety, especially the increasing variety. So just a word on that, it's not a one size fits all. So increasing volume is prioritized when someone is undernourished and underweight. They're unable to consume enough energy until their kind of wellness weight is reached. But increasing variety of intake is a tricky one, because if they are kind of covering off their bases for reducing risk of micronutrient deficiency, then we might not actually need to push that. And keep in mind, nutrition supplements do exist. And so I find a lot of clinicians are hesitant to recommend oral supplementation with vitamins and mineral replacement, but I really like to use those to kind of get our foot in the door, really start to work on like to correct the nutrition deficiency. And then we're buying ourselves some time while we're trying to build up with the patient's agreements to build up to food sources of that deficiency. I'm gonna maybe this is just to say the path to the refeeding process or nutrition rehabilitation tends to focus on the foundation of enough. So really just focusing on the volume, and then the other things come once we have that foundation. And sometimes we never get past the foundation, and that can be okay. There is an iteration of CBT for RFID, and so I'll just leave that there for you folks. It is very structured with 4 defined phases. Exposure and response prevention, or ERP, is a structured and stepwise approach with repeated exposures to feared foods, emotions, or behaviors. Does tend to target the avoidance behavior, so relevant to the GI population specifically. And primary goals include increasing the overall food intake and decreasing anxiety. And then ACT would be the last one. So acceptance and commitment therapy is a treatment approach that highlights compassionate acceptance of thoughts and emotions alongside the commitment to make meaningful behavior change. So just to summarize, prescriptive diets are not without risks. Try to consider the full picture prior to recommending and implementing. Continuous assessment of maladaptive presentations can help us clinicians identify early signs of disordered eating if present. Tailoring patient interventions to their specific needs is essential to prevent and or improve food restriction as well as their nutrition status. And finally, if there's one point that you remember, keep the patient at the center of care. So consider their past experiences and possible medical trauma prior to making your own recommendations. And I just want to give a big thank you to our intern, Andrea Dominez. She helped with a lot of the foundational research. And I believe our slide decks, I don't know if they're going out, but I'll keep them on the screen for a second, just in case anyone wants to read into them further. Thank you, folks.